And the session will be moderated by Dr. S.K. Gupta, Senior Consultant Physician, Shivam Nursing Home, Selampur, Delhi. And chairpersons are Dr. B.B. Rewari, Medical Officer, Hepatitis, HIV and STIs, World Health Organization, Regional Office for Southeast Asia, and Dr. Arjun Khanna, Senior Consultant Pulmonologist, Yashoda Super Specialty Hospital, Koshambi. So I invite Dr. Ruby Bansal to start the session.
Ruby, before you take over, I think it is, I should be adding something. First of all, thank you, Dr. Paras and the other members of the EDPA, and we welcome Dr. Rewari. Thank you, sir. Thank you for being here with us, and we are very pleased to see the WHO logo behind you. We have had a number of meetings on the EDPA platform and the international forum, but first of its kind, with the WHO man sitting among us and ready to guide us. Thank you, sir, for being with us, and thank you, Dr. Arjun Khanna. He is the senior consultant and the director of the Galaxy Hospital. We don't find him to be very, very august because he's so near to us, very dear to us. And thank you, and a very knowledgeable person. And of course, Pankaj is always there, and Dr. Ruby has been doing a lot of work. And as other members have already said, that the HIV has changed scenario. In the time we read it in the postgraduate classes, and now this is one of the diseases in the world which have been conquered by effective treatment. And what are the changes in the treatment? We should all get upgraded. And I invite Dr. Rewari, you want to say something before we proceed, sir?
Good evening, and Dr. Gupta, thank you for giving me this opportunity to be among you. I could really sense the feeling of being a family with the sentiments expressed by Dr. Paras, Dr. Swati, Dr. Bansal, and Dr. Pankaj. I am not new to EDPA. I may not have interacted with all of you, but I have participated in a number of conferences because your past president, Dr. Vijay Arora, was my senior resident in RML Hospital. So I've been regularly interacting with him and many others in the EDPA. And I know it's a very academic oriented body because I've seen this from 3 conferences that I've attended in the past before the COVID came in. So it is good that Dr. Gupta asked me to be part of this academic activity. Just one thing I just wanted to say, which Dr. Pankaj mentioned about being HIV specialist. No, we are not in that era now. Nobody is HIV specialist. Some people have more experience because they joined this platform early, and now everybody has to join in. Because HIV treatment has become so simplified that anybody can treat it with little orientation. And I'm sure series of these sessions that will be held after this one also will actually help people to treat patients without any discrimination and without any difficulty. Another important point which was, I think, brought up by Dr. Pankaj himself was early diagnosis. So our main aim with treatment being so simplified that anybody who is found to be positive, irrespective of CD4 count, viral load, gets drug, and the commonly used drug is single pill of 3 drug combination. So it's so simple, but still, if I give you data from NACO, 35% of patients who come to NACO, and they have 1.4 million on treatment. So you can imagine out of 1.4 million, 35% will be some almost 40,000. 40,000 people presented with a CD4 count of less than 200. They came with the advanced disease. And mortality in HIV initial 6 months among advanced disease, 50% of patients die within 6 months with advanced disease. So it is important to suspect early. That is the crux of basically HIV. And we know there are a number of indications, number of indicator illnesses which are actually missed out. So I think this session will be very useful. And Dr. Ruby Bansal is an accomplished person. She has been treating HIV and has got number of lectures at national, international conferences and needs no introduction. So I'm pretty sure that this series will be very helpful. Thank you.
Thank you, sir. Thank you. Thank you for the kind words. Thank you, EDPA, for starting this series. And I'm very happy. I'm just starting this series with in front of my mentor, Dr. Rewari, and many seniors from the EDPA who has always been very supportive. So since last 18 years, I am a member of EDPA and I'm working with them. So, and always got the, wonderful support from all of them, starting from the Dr. Gera, Dr. Neerajan, Dr. Grover, and so on, in the young team. So my congratulations to the young team. And I believe with Dr. Paras being a president, this will be a very, interesting inning of this EDPA. Not only in the academic way, but also in the social aspect. So I will just share my screen. So just a moment. Is it visible?
You are visible, Dr.
No, my screen is visible.
Your screen is also visible.
Yes.
Okay. So
Yeah, it is visible. It is visible.
it's not
It
visible.
just
to
says
me.
you are sharing your screen. Ruby, it says you are sharing your screen, and it's a white
Okay.
slide at the moment.
Oh, okay. Just a minute. So give me one moment. I think there is, I will just again try to share a screen. It's not coming.
Come.
You stop sharing, then do it again.
Sorry for the glitches.
Take your time, Ruby. Take your time. First time,
Your
take
time.
some more
Take your
time.
time. Yeah. Screen was there.
There is some error, I think, showing.
You were able to see your slides once in the beginning.
Yeah.
रूबी पहले स्लाइड्स को डाउनलोड कर लो, स्लाइड्स को डेस्कटॉप पे ले आओ and then you can start doing it.
नहीं है. Slides are on the desktop. Usually it happens. I'm just doing it quite often. So I don't know what's wrong.
आपने मिनिमाइज तो नहीं कर दिया? नीचे चले गए स्लाइड्स.
Ruby is a seasoned player, so there has to be good level of glitch.
Yeah, usually it does not happen, but I don't
Have you
know.
changed your device, or maybe are you on iPad? Then the life becomes tough.
नीचे देखो क्रोम
Yeah.
का या पावर पॉइंट का वो आ रहा है, उस पर क्लिक करो, आपकी स्लाइड्स खुल जाएंगी. और you stop sharing, then दोबारा से शेयर करो.
What's wrong? What's wrong? I'm really sorry.
Swati ko
In initial phases it was said that COVID virus is like HIV virus, and definitely it has a little bit of the same sort of the structure. It is isosceral enveloped virus of the lentivirus subfamily of the retrovirus, lentivirus family mainly. And you can see there are multiple antigen. It is a GP41 envelope protein, which is in the red, you can see in the outer surface. GP120 envelope protein, which is in the purple. You can see just like a cap on the red surface, and this is the lipid membrane, which you can see is a orange of the color, and the P24 capsule protein, which is a capsule. It is the capsule, mainly the P24 antigen. Once we are detecting the P24 antigen sometimes in the test. So this is outer envelope contains lipid matrix with which the viral glycoproteins are embedded. So there are multiple, and we have a lot of apart from the P24 antigen, we have a lot of other antigen associated with this virus.
P24 antigen is important because we are going to test this antigen while we are doing the antigen testing.
Yes. So next slide. Mode of HIV/AIDS transmission, I think everybody knows, but for the young students, you should understand what are there are a lot of myths among even the medical fraternity. What are the mode of the transmission and how it can transmit and how it cannot transmit. Next slide.
No, so just to highlight here, it's modes of HIV transmission, not AIDS transmission.
Yeah, it's a modes of HIV.
No, we should be clear on that. It's the modes of transmission of HIV, not AIDS.
Yes, it's HIV is a virus. Only HIV virus can transmit, not the AIDS. The disease per se, opportunistic infection doesn't transmit. So, sir, rightly said,
Dr.
maybe in
Ruby,
my
I
slide.
specifically mentioned because your slide said modes of HIV/AIDS transmission.
Sorry, sir. I got your point. So it is the virus. It is a transmission modes are modes of transmission of the HIV virus. So it is blood product, semen, vaginal fluid. Next. So a needle with any kind of the infected needles, sharing needles, unsterilized bed, blood transfusion. So all, especially now it is very rare with the blood transfusion, but infected blood can transmit this. Next slide. Through sex, vaginal and anal. Anal sex is the most transmissible, and vaginal, then the oral, unprotected sexual intercourse. All three modes can transmit this HIV. Next. Mother to child transmission. Definitely in the mother to child transmission, it can happen in the three ways. It's a before birth, during birth, and during the postpartum breastfeeding. So these are the three modes of the mother to child transmission. Next slide. Myths, definitely. There are a lot of myths. One can infect while sitting with patient. No. Eating together. No. Work together. No. Shaking hand. Sharing toilet. Sharing swimming pool. Sharing towel. Sharing clothes. Casual kissing. Hugging. Even the mosquito bite. All these are the myths about the transmission. HIV does not transmit through all these methods. Only whatever the methods I told, transmission mode, only that way it can transmit. Otherwise, in normal casual contact, it does not transmit. Next slide. It is an old slide, very old slide. I was looking for the new one, but AIDS diagnosis by transmission category, mainly maximum transmission is in the gay population and in the MSM, means the anal sex, mostly in anal sex, then the heterosexual, then infected drug user, and after that the other regions. And definitely if we are treating all the mothers who are HIV positive, so mother to child transmission is now minimal, or even you can say you can save the baby 100% if with the interventions. Next slide. Natural course of, as everyone started how to diagnose, when to think. Dr. Paras asked when to think about HIV. So I will just hear the few things, what are the symptoms can be there. Next slide. So HIV is a stage-wise disease, but even if stage 1 this is a primary disease, when the seroconversion happens, and where actually this is the time when we should diagnose the patient. This is the, and it is, at this time, hardly any patient be diagnosed unless tested, basically, because unless tested, unless tested for the HIV, you cannot diagnose the patient. And initial symptoms are the very, very vague type of symptom, flu-like symptom. It is just a, people used to think it is a viral infection, it is a sore throat, it is a running nose, it can be a mild fever for 1-2 days, or it is a very, very mild symptom. So hardly any physician think of HIV here. and which is the place. This is the time when every
Dr. Ruby, kindly please tell that how much time does it take for the acute HIV infection to come as symptoms? How much time after the exposure the patient is likely to develop these symptoms, and how much time do these symptoms persist without treatment?
Yeah, I will come with the stage, sir. So this is the time when 1 to 6 weeks after the infection, flu-like symptoms. It is not just a same day. It will not come. It is when the virus will enter into the body, and basically because it is started. When we get the antibodies started developing, it is for the any virus. When the virus is entering our body system, mechanism is just all the antibodies are coming. T cells to fight the virus. At that time, only the symptom will come. So, because the virus is at that time, it is in quite high numbers in a acute seroconversion time, and suddenly it is a very low CD4 count. Maybe you can, if you diagnose early. We have a couple of patients, many patients where we've seen this, and this infection will be maybe sometimes it is a sore throat, and sometimes it is a lymphoadenopathy, especially even mumps-like picture. If the patient is coming with a mumps-like picture, one should think of the testing the HIV and history. Important is history. We are not taking any sexual history from the patient, any patient who is coming to your OPD. I don't know how many of person are you asking about the sexual history. I don't think so. Anyone is asking about the sexual history, basically because sex is a taboo in our society, and if you are asking the sexual history, it does not look nice for the patient, and he feels ki what is Dr. Sahab, mera character aisa thodi na hai. I am not like that. So such things are happening. That's why the diagnosis is missing in this acute phase. And even if you can see in the picture, can be acute infection can be any kind of symptom. If the central nervous system, malaise, headache, neuropathy, systemic fever, lymphadenopathy, skin rash can happen. So sore throat, soreness of the mouth, oral thrush can be there. So not in all cases. Next slide, please. Dr. Swati, next slide.
Acute retroviral syndrome occurs in about 50 to 70% patients. As Dr. Bansal said, it does not occur in all the patients.
Yeah. My screen is Dr. Swati. I can't see my screen. Hello, Dr. Swati. Is she there? Dr. Gupta?
I'll be sharing in case the Swati is kindly wait. You'll have to wait for a moment, please.
So even next stage comes stage 2, which can be mainly even asymptomatic. We used to say it is an asymptomatic stage.
Swati, are you live? Can you, the share has stopped.
Sir, I'm sorry. Actually, there was a power cut. I got disconnected.
If there is an issue, I can share my slides, which are similar slides almost. We can continue with that.
I
No,
think
actually,
Ruby will
now
be more
I'm
comfortable
connected.
with her.
Hopefully, this issue won't come again.
Yeah.
Yeah, next slide, please.
Next slide.
Slide.
Sure.
Yeah, second stage is asymptomatic stage. Sorry, Dr. Swati, just go back.
2 slides back.
One more, yeah. So it is a mostly asymptomatic stage. It can happen it can be long up to the 10 years, even the more. Even many few cases we have seen it is the 15 years. Dr. Swati, please, yeah. This stage is free from the symptoms, and this is the stage when the maximum transmissions are happening. When the because the person is not sick, so he is continuing with the behavior, the sexual contacts maybe, and this transmission can, this stage can, in this stage, the virus can be transmitted to the others. So there may be the swollen nodes, which can go unnoticed, the level of HIV at this stage, we don't find much level of the HIV virus. So,
Dr. Rewari, may I ask you to intervene?
The virus and there is.
Dr. Gupta, you said something?
Dr. Ruby says that this asymptomatic stage lasts for an average of 10 years. The word should be average or should be median?
This varies from actually 5 to 8 years, but depends on many things. It depends on basically nutritional status of the person. It depends on the opportunistic infections that he's getting. And to some extent, it also depends on the virus, also the strain of the virus.
Strain of the virus.
Good.
So at this time, there is no window period. So HIV bodies can be detected in the blood. In the early seroconversion, when it is a seroconversion, you may not get the HIV antibodies in the blood, even if you are testing. So, but this stage, if you go for the test, person can come positive. But it is asymptomatic stage, and where it is the stage where we are not absolutely suspecting the disease. That's why not advising the test, and people are also not getting the test. Next slide. This is the third stage. This is the symptomatic stage. The immune system deteriorates basically because what happens with this disease, HIV virus enters into the body, it starts replicating. So once the virus is replicating and it is there is a fight, continuous fight going on with the immune system and the virus. So CD4 cells counts are decreasing and the virus is increasing. So as virus increase and as low will be the CD4 count, then the system starts all the disease starts. Person is with the weakened system, a weakened immune system, so all disease can happen. Anything can from anything this patient can be infected because of the low immunity. So persistent infections, there are list of the persistent infection. Any infection can happen at this stage, symptomatic, where most of the time we are getting the patient long duration of the fever, diarrhea, oral thrush. We are getting patient with the you can see with the hairy leukoplakia. We can get the patient here with the herpes. We can get the so many, any kind of the disease can happen at this stage. Even the tuberculosis, PCP, so many. I will just show further.
Ruby, I'll intervene. So what happened in the beginning that the patient got infected, the virus got into the blood, the virus started replicating itself. About 50% patients had an acute retroviral syndrome in the form of fever, lymphadenopathy, and another 50% or the 50% who got the retroviral syndrome, they also improved within a week or so. And most of the patients, like all of the patients, will remain asymptomatic for a long duration of time, that is about 5 to 10 years. Median of about 10 years, and during these 10 years, the virus keeps on replicating, and starts on attacking the CD4 cells, and the CD4 they continue to decline. Once the CD4 cells decline below a certain level, the opportunistic infections they start invading the body, and the patient presents with the opportunistic infection, and then he comes to the hospital. And otherwise, he or she remains asymptomatic and has the maximum chances of transmitting the disease. Initially, it is important to understand that the CD4 count directly correlates with the opportunistic infection. Lower in the CD4 count, more in the opportunistic infection. In fact, even two opportunistic infections, they can occur together. And in the higher CD4 count, the CD4 count normally is about 500 to 1400. And when the CD4 start falling below 500, the patient, they will start developing the opportunistic infections.
Yeah.
Dr. Gupta, I would just like to come in here because these CD4 correlation is there definitely, but even in, as I said earlier, there are opportunities for actually diagnosis. When the person's CD4 count is still high, but they might have symptoms like unexplained weight loss, where you ruled out other causes of which is more than 10% of body weight. You ruled out hyperthyroidism, you ruled out TB, you ruled out diabetes. There is unexplained diarrhea, unexplained persistent fever for more than 1 month. Person has oral candidiasis, not being on steroid or any immunosuppression. These are some of the indicators which here you can get patients at early. You can detect them early if you suspect, because mind suspects only, and I see only what the mind knows, and tuberculosis particularly. Tuberculosis can occur even at a CD4 count higher than 500.
500,
So it is a
yes.
different type of tuberculosis. So any person having tuberculosis must be offered
Okay.
HIV testing. Our focus for this session, Dr. Ruby is also trying, is on early diagnosis. So we should focus on these cardinal signs of early diagnosis, because if he has come with opportunistic infection, CD4 count less than 200, outcome
Mortality
will
is
not
high.
be the similar.
The
Thank you.
diagnosis is correct. So cardinal symptoms: the fever, unexplained weight loss, oral thrush, and one more, unexplained diarrhea.
Any STD, sir, any STD. If there is a person is having any STD, he should be offered the HIV testing. Tuberculosis patient, he should be offered the HIV testing. All the pregnant women should be offered the HIV testing. And like even herpes, every patient who is herpes, who is not history of the contact, should be offered the HIV testing. So these are the main symptoms: oral thrush, candidiasis. So these are the things which we see early, and these patients should be offered the HIV testing to diagnose it early. I mean, I have seen the patients who have been done the PAT scan even, but not the HIV testing. To rule out the disease, they have done the PAT scan, all kind of the CT, MRI, everything for the patient is not for the fever of unknown origin, but not the HIV test. So this should be the part of the differential diagnosis of all our suspicions. Next slide, please. So stage 4, definitely stage 4 is when the viral load is very high and CD4 is very less. So then this is the time when we used to say ki HIV is converted into the AIDS and person is having the multiple opportunistic infection. So though lot many infections can occur at that time. I will now, my few slides will tell you in what stage, what kind of the opportunistic infection can come. Next slide, please. So associated with the AIDS, CD4 less than, I mean, opportunistic associated with the HIV infection. I should not say it is a AIDS. So sir will again say, I'm sorry, sir, I'm using the word say here, AIDS. It is with the HIV. CD4 if less than 500. Although sir has told already, Dr. Rewari, if the CD4 is more than 500, then also the tuberculosis is the disease which can occur, basically because India is an epidemic. I mean, India is like a capital of the TB also. We have a lot of the TB infections. So in India, the most important opportunistic infection is TB, and most common opportunistic infection is TB. So every TB patient should be tested for the HIV. There can be any kind of the bacterial infections, tuberculosis, herpes simplex, herpes zoster, vaginal candidiasis, oral hairy leukoplakia, even the Kaposi sarcoma. Although we don't have the much of the Kaposi sarcoma, it is more prevalent to the African countries, but still, if you see such kind of the rashes, one should think about this also. Next slide, please. So mainly opportunistic infection, if the CD4 count is less than 200, I mean, apart from all what I showed in my previous slide, you can add these infections also. This is the PCP, pneumocystis carinii, toxoplasmosis, cryptococcosis, coccidiomycosis, cryptosporiosis, and non-Hodgkin's lymphoma. All these can happen. This should be also part of your differential diagnosis if you diagnose the patient with HIV and having, I mean, admitted or you are seeing a CD4 count less than 200. Next slide, please. CD4 count less than 500. So this is a different kind of the different set of the disease. MAC is very common. Histoplasmosis, CMV retinitis. I have the patients who have CMV retinitis and get the blind. So there is irreversible disease. I mean, the blindness, it cannot be reversed. And no one has test for the HIV. They treat with the CMV retinitis, but no one tests the HIV and the patient just got the blind. I have the 3 patients who are the blind with the CMV retinitis. They came in a very late stage with the CD4 count. One came with the 20, one foreigner patient came with the 3 CD4 count. So CNS lymphoma can be, PML is a very common thing, progressive multifocal leukoencephalopathy, difficult to diagnose and difficult to treat. It also can be there, HIV dementia, and Kaposi sarcoma I have put here also, basically because in India we don't see much of the Kaposi sarcoma, but still, as it is a medical tourism, is a lot many there, and in the corporate hospital we can see once we are getting the patient from the outside. Even in India also we find these cases, but less. Next slide.
Dr. Ruby,
Rivadi,
Dr. Ruby, I will intervene. I
Yeah.
think you better cover the laboratory diagnosis because we are going to have a separate session on the.
This is just a one slide. I am not covering the TB. TB HIV co-infection. I just put this one slide. TB is the most common opportunistic infection in HIV. It is and the first cause of the mortality in HIV infected patient. 10 to 30% mortality is due to the HIV TB co-infection. 10 million patients co-infected in the world. Immunosuppression induced by HIV modifies the clinical presentation of TB. Definitely, we see the different type of the TB. Maybe the bilateral tuberculosis, maybe the more of the lymphadenopathies, extrapulmonary tuberculosis, and the high rate of the MDR, XTR also, and the even relapse, chances of the relapse also much higher than in the normal only TB cases in HIV TB co-infection. Next slide. So TB and HIV is a double trouble and double burden. We need to think of. Next slide. Testing option. Definitely, everybody is asking for the testing option. NACO has the guideline. I've sent Dr. Gupta to you this NACO guidelines. There is the testing guidelines also mentioned there. So testing option for the HIV. Next slide. So there are many tests now available. So this is the rapid P24 antigen, ELISA test, CAR test, NAT testing. NAT testing mainly we are using in the blood banks. So nucleic acid assay, it is a sensitive, very sensitive test. HIV ELISA. HIV ELISA is a screening test for HIV, sensitivity more than 99.9%. And the Western blot is, this is not of a routine. It is, we are phasing out Western blot, basically no need of the Western blot test. Only if you are suspecting, if there is this is a confirmatory test when, especially in the pregnancy, sometimes we do, when we can get the false positive result and patient is in the panic state. So sometimes I used to do, or we are, even if we have a dilemma of HIV1 and HIV2, then we are confirming it is with the Western blot. Otherwise, we are not doing this Western blot as a routine. Only 3 tests, either with the different antigen test kit or with the different methods. If out of 3, 2 positive comes, so you can just, if the 2 positive, then only you can label the HIV, you can label the person HIV positive. Basically, a lot of time we are seeing labs are doing only the one test, CAR test, and releasing the report of HIV positive, which is wrong, which is not up to the mark. And NACO is taking, I mean, lot of actions against these things. And I mean, this is basically, we are trying to teach every lab, there should be the 3 tests at least. Antigen, not with the 3 CAR tests. 3 CAR tests, if you are doing with a different antigen kit. As we told, there are the multiple antigen with the HIV virus. So if the 3 antigens are positive, if you anybody has seen the Western blot, it is showing the 10 or 12 antigen. So how many are positive? So, but in the routine, we can do with the 3 antigen or with the 1 CAR test, 1 ELISA, or you can send the 1 NAT, or maybe the 2 CAR sets, CAR test and the 1 ELISA. We have the test absolute CD4 count. We are starting, say, we are talking about
I'll just intervene for a moment,
yeah.
kindly.
I would also like to intervene here.
Sir, sir, please, you first.
Yes,
so
sir.
Because when we say we have to do 3 tests, let us be very clear that these 3 tests are to be done on 1 sample only.
Yes.
You perform the first test. If first test is negative, just report negative. Then if first test is positive, do a second test. If second test is positive, still do a third test.
Yes.
Only when your all 3 tests are positive, you report is a reactive. This is to take care of the sensitivity and specificity issue, because your first test is 100% sensitive, but it is 99.8% specific. Similarly, the second test has got also a specificity of 99.9%. So you need to have 3 tests. And as Dr. Ruby said, most laboratories do a single test. These can be 3 antibody tests. This can be 1 antibody, 2 ELISA. It can be any combination. Even 3 antigen tests with a different antigen are okay. Only when there is a discordance, there are issues about repeating this test after 3 months. Western blot is not required in any condition now. There is no recommendation to do a Western blot. Thank you.
And what I wanted to say, as Dr. Rivadi said, that it is important to have different tests rather than to jump for the Western blot test, because Western blot is also an antibody-based test.
Yes.
It is better to go for a antigen-based test, and as maybe because initially all we have is the ELISA, which is antibody-based test. The Western blot is much more specific antigen antibody test, and it is more important to have
Dr.
different.
Gupta, Dr.
No,
Gupta.
no. Basically, we have to
No,
test
no.
with antibody. Yeah.
What we are doing basically, 3 tests are basically detecting the antibodies.
Antibodies.
They are not detecting antigen, while Western blot is detecting antigen, but specificity of Western blot is not very significant. It is not required for confirmation. If
Yes.
you've done 3 antibody tests, means 3 tests with different antigen who detect antibody in the blood, that is enough for diagnosis.
So how do we know that this kit is a different antigen and
Yes,
that the kit which
these
was
are
done
kits.
earlier?
These
It
are
is written.
specified on the kits.
Yeah, it is written on the kit box.
Does it do the antigens or the impregnated on the card vary with the company?
It will be written which are the first kits. Basically, there are different types: first test kit, second and third test kits. So it is specified on the type of the kit, which is the first test kit, which is the second kit, which is the third kit. So laboratory people will know this, but you have to ask your laboratory person, have you done 3 tests? For confirmation. For ruling out, 1 is enough.
Now it is mandatory. They have to mention all the, on the report, they have to mention all the tests, which test they have done, what kind of the first positive, where the second test is positive and third test positive. Then only they should release. Only you can see in the Lal's lab report, you will find all these tests written sometimes, not in the many labs. I'm not promoting the Lal lab, but I'm just saying the format is something different, and they are just mentioning also it is a confirmatory test. You can even further go for the counseling and the treatment. So that is always important. The testing is very, very important because false negative also there and false positive also there. So we should be very, very specific, and this is a lifelong disease. So we should be very sure before labeling the patient HIV positive, we should confirm the diagnosis. So there is absolute CD4 count we are talking about. CD4 count and viral load is important when we are starting the treatment and we see the progress of the patient. How basically, because once we start the treatment, the CD4, first the viral load will start reducing. So we will reduce the viral load and gradually the CD4 count start gaining. So it increase. So that's why we need to do these tests. And now all the government organization also doing the CD4 and viral load testing. It is RNA PCR. There are 2 tests, RNA PCR quantitative, qualitative. There is a DNA PCR also. DNA we are doing for the infant diagnosis. We are using this technique for the infant diagnosis. RNA PCR quantitative is important to know the viral load. This mistake is happening every time in the hospital. Once we ask for the viral test, they are doing the qualitative. Qualitative is just to detect the virus. They will give us a report, virus detected or not detected. But we need if we start the treatment and we working up the treatment, we have to write particularly RNA PCR quantitative viral load for HIV-1 or HIV-2. So we have to be particularly writing properly, and then only we can get the proper result. So next slide. Any question in this testing? Further, Dr. Gupta? Hello.
How often a patient should be taken for the CD4 count, and how, because many of these patients they can't afford the viral load, and and many times the government is just doing the CD4 count.
No, sir. Government is now doing the viral load very well. So we should not blame the government. Every government ART center, especially in the cities, they are doing the viral load. So this is a very Dr. Rewari.
How often should we do? How often should the patient be subjected to this?
Starting, we are monitoring these patients with the 6 monthly. If the viral load is undetectable in 3 consequent tests, then we are doing it with the yearly. And after that, we are, even if the CD4 count reaches up to the 400, 500s, and we are not, the government centers are not doing the CD4 count anymore, and they are just checking it with the viral load. And in private, we are doing it. Basically depends. Once the patient is settled, once in a year. Otherwise, in starting, I'm personally doing in starting. I'm doing the viral load after 3 months of initiating the treatment, and then 6 monthly.
But the WHO guideline, the WHO and NACO guidelines are You
6
don't
months.
need a baseline viral load because everybody will get ART irrespective of viral load or CD4. You do viral load 6 months after initiation of ART, then again at 1 year, and if virally suppressed, then every year.
Every year. So oral testing, there are a lot of noise about the oral testing in Western world. They are doing the oral testing. There are the kit, FDA approved kit, HIV antibody kit. It is accurate as blood testing, but it is maybe there are the saliva testing also available, but they are not approved in India basically because there are a lot of thing about the confidentiality, there about the counseling, and specifically linking to the ART center. If you are just doing the oral testing, who is going to tell them what to do? So that's why in India it is not yet approved, and we don't know, maybe in the future where there will be any approval for these oral testing or the self-testing means.
Just
So-
to add to Dr. Ruby to this,
Yeah.
it is not as such approved, but HIV self-testing is now being done at 20 sites in the country. Some 50,000 tests have been procured. These are being actually tested, and those who are found to be positive, they are being linked to ART centers. But it is in a pilot stage, not
Yes.
available in the market as of now, as you rightly said.
So thank you. Next slide. So treatment options. Yes, we have the now full basket of the treatment, whatever available.
Yeah, Ruby will come
Yeah.
up to treatment options later on, and I have some questions which might be pertaining to the physicians.
Yes, yes, yes,
And
sir.
very
Yes, sir.
important, and they are all concerned.
Yes.
And how the physicians can get infected by the HIV because they don't operate, and they are not gynecologists who handle the vaginal secretions. The physicians are concerned. How can they be infected?
Sir, this is a needleistic injury. I think I have taken a couple of the times in the EDPA, needleistic injury and the post-exposure prophylaxis. So this is basically in the during the needleistic injury, it can happen. It can happen in the operation theater with the splashes, but definitely the patients who are not on the treatment, who has a high viral load, the chances are high. Otherwise, the needleistic injury transmission is 0.03%. So it is a very minimal. We see the hepatitis B transmission is the highest, then the hepatitis C, and then the HIV. Only due to the lack of knowledge and lack of this thing, people are more worried about the HIV needleistic injury, basically because mostly in the recapping, mostly in the OT, while transferring the, while sharing this instrument, while suturing, especially suturing orthopedician and all these, and gynecologists definitely when there is a like a splash on their mouth and this thing. So standard precaution, if someone is following, and after the COVID, I think everyone is following the standard precaution. Even earlier there was some resistance or some this thing. So if this transmission is much rare than the COVID, what we have seen in the COVID. So it is a oral transmission. It is with the body fluid. Only the body fluid when enters into the another body, then only the transmission can occur.
Dr. Obi's question was, how can physicians get it? Not the surgeons or this.
No, sir. He has asked especially surgeons and gynecologists.
Okay,
also.
okay. I thought he's asking for.
No, sir. You rightly said, how can physicians get it?
Yes.
Physicians cannot. It is not while you are seeing the patient, you cannot get this infection. If you are doing the procedure, you are doing the pleural tapping, you are doing the ascitic tapping, you are doing any invasive procedure, then only there are chance of the needleistic injury. Otherwise, while seeing the patient, there is no need of wearing the gloves, no need of wearing the mask or this thing. You can see because it is not a transmission by touch. It is not a transmission, airborne transmission. It is only once the internal body fluid of the infected person can enter into the body of the other person or other physician.
Fine. That's wonderfully explained. Now, somebody has got a needleistic injury. Then what is the next thing that he should do immediately? He should test himself. He should squeeze the blood. He should apply spirit. He should apply betadine. He should get panic and rush to Ruby.
You want all this me to explain, or we have to take this?
This is important. This is pertinent to all the physicians.
Okay, sure. Needleistic injury. First thing, don't panic. I remember the first slide of Dr. Rivadi is a long back, 20 years back. So it is the first slide of his is don't panic, and this has just sit in my brain. So first thing is don't panic. I always teaching the nurses, and I am just teaching them, don't panic. Like report and hand over the work, whatever you are doing, to the other. Then do not squeeze. Do not put the finger in the mouth. Do not try to squeeze and bring the blood down. Only simply wash with the soap and water in the running water. Just put your hand down and just if the finger is pricked, just wash. No antiseptic, no any kind of the solution is needed. I have just received a call long back from the OT कि डॉक्टर साहब मेरे सुई गिर गई थी, स्कैल्पेल गिर गया था पैर पर और मैंने पैर को बहुत देर तक साइडेक्स में रखा है तो अब तो मुझे कुछ नहीं होगा. So please don't do this kind of the things. There is no need of the any kind of the antiseptic solution or anything. Just plain wash with the water and the soap. If
That's
the
fine.
patient test for the HIV status, hepatitis B and hepatitis C, check for the hepatitis B vaccination. This is very important. And if things happens, report, and we have the prophylaxis for this. One can, if the patient is HIV positive, there are the whole protocol. Who should take the prophylaxis, who should not take the prophylaxis, which prophylaxis, 2 drugs, 3 drugs. So there is a whole protocol.
Then how should the physician go for the testing? Suppose like if the one has washed or one has forgot to wash, then one is concerned whether he or she is likely to get infection or he has already got the infection. Then how should he or she proceed with the testing?
We need to do the basic test. Basic test is to rule out the previous infection, not this current infection. We will not get, there is no such test which is just prick and test, right? So we can get the answer. So this is we are testing person for HIV to rule out the previous infection, right? And after that, the protocol is the 6 weeks, then the 3 months, and the 6 month maximum window period in a very rare cases is up to 1 year. Patient who are very conscious and this thing they can just do after 1 year, although the protocol is 6 weeks and 3 months.
Does the NACO or Dr. Ruby or Dr. Rewadi recommend the surveillance every year for all the physicians?
No. No. If you are following universal work precautions,
yeah,
you don't require surveillance every year or infectious disease checked every year.
That's wonderful.
Even in the post-surgical cases, NICO is not promoting the testing. So there is no need of the test for anybody who is not having the risk. But otherwise it's good to test each and every one.
And what are the support groups available to the physicians or to the doctors who can help them to get the post-exposure prophylaxis or to guide them further?
So for EDPA, I am there. For everybody, for the Gynae Forum, Delhi Gynae Forum, I am there. And there is the NACO. Delhi has, I think, more than 15 ART centers. All the hospitals are providing the PEP. All the hospitals are providing, who are the ART centers are providing support. And so there is no extra or something special things are required. And I am there for all. So anytime.
That's really wonderful.
The point here is, I want to add.
Yeah.
You may not be available all the time. You may be in flight. You may be in US.
Yes.
So the solution to this problem is every hospital should have a written protocol on PEP. Not only what is the protocol, where will they get the drugs, and it should be displayed at least 3 places in the hospital. That is emergency, operation theater, and OT. And this is actually a guideline for government hospitals, but private hospitals may not be following this. But since you are in different hospitals, I feel there are posters available. There are posters available which can be put up in your hospitals.
Yes, sir. All the corporate hospital has the needle stick injury and post-exposure prophylaxis guideline, well placed, and they are following this. All the testing basically because there is an infection control committee which is handling this but only thing the reporting should be there. Infection control nurse is there. So if anybody gets injured, they have to contact the infection control nurse and they do all the things. Especially I'm talking about the corporate hospital, small nursing homes, definitely they are lacking this protocol and the knowledge. I'm trying wherever I can just do, and I'm still available for anybody who wants this protocol to develop, who wants these things to develop to empower the staff. So I am available for them for the district injury.
So Dr. Ruby, I would request you to kindly frame such a small protocol so that all these small nursing homes and we can have their poster printed by the EDP.
Sure.
So that everybody is benefited.
Yeah. So shall we move further?
Sure.
So there are treatment options. I'll just keep the 1-2 slide for the treatment options. So it is not because treatment we will take separately in a one session. So treatment option, next slide, Dr. Sati. So there's a ART era. So ART or HART, highly active antiretroviral treatment. ART was only when the Zidovudine was there. So when there are multiple drugs came, so the terminology has been given the HART, HART, highly active antiretroviral drug. There are multiple groups, NRTI, NNRTI, non-nucleotide reverse transcriptase, non-nucleotide reverse transcriptase, integrase inhibitor, protease inhibitor, fusion inhibitor, and the CCRP analogous. So here only the 4 are available, but we have the different more group in our basket. So as I told, the India has all the medicines which are available anywhere in the world. Most of them which are in the guidelines, in the WHO guidelines, we have all the available in our country, and we have a full basket of the HIV medicines with us. So NRTI, if we talk, next slide please. I will just name because I will take, that's why antinucleoside. NRTIs, there are the different drug. Earlier it was the Zidovudine. Zidovudine is already phased out from the program, although it is available, but it is available for the special situation and the patient who are doing well with this. But these are the NRTI: Zidovudine, Lamivudine, Abacavir, Emtricitabine, Tenofovir, Stavudine, and this TAF, which is newly available. So these are all comes into the NRTI. NNRTI, this is the, Nevirapine. Nevirapine is again phased out. Efavirenz, we were having. Efavirenz is also gradually phasing out due to its neurotoxic effects. So government program it is phasing out, but many patients are doing well and they are continuing with this drug, this 3-drug combination, TLE or TEE, tenofovir, lamivudine, and efavirenz, or tenofovir, emtricitabine, efavirenz. We have the integrase inhibitor. This is the protease I mentioned. I have not mentioned the 2 other groups. Protease inhibitor, there are atazanavir. This is the darunavir, lopinavir, ritonavir. They comes in the protease inhibitor. We have the integrase inhibitor, where the dolutegravir and deltagravir and the bictegravir comes. So dolutegravir is now in the picture, and we are using in the even WHO guidelines. As per the WHO guideline and NACO guidelines are also saying the 2 NRTI and 1 integrase inhibitor to start the treatment in the first line. So we can have maybe the this tenofovir, emtricitabine, and dolutegravir. We can have tenofovir, lamivudine, and dolutegravir in our treatment. So I will take this when we'll take this total the treatment part. Fusion inhibitor, this is the, we don't have the fusion inhibitor available. CCRP antagonist Maraviroc, we have the available with us in India. Next slide, but I will take this in the separate session of treatment. Primary prevention, we all know, abstinence because this is sexual transmitted but not feasible. Monogamous relationship definitely is feasible, but now the generation is not into the monogamous. They have the multi-gamous relationship. Protected sex, that is where we can emphasize the protected sex. You cannot say no to sex. You cannot say only the one partner, even to the current generation. So protected sex is a better word they want to listen. So everybody who is seeing the adolescent, who is seeing the youngster, even their own children, so always tell them about the protected sex. So use of the condom. Sterile needle, definitely it is a part of the national, international, all programs. Everybody should use the single-use needle, not the multi-use needle. So for the any kind of the work, new shaving, cutting blade. So every barber or one should be ensure that he is using the new blade, not the used blade. Tattooing is very important. People are getting the tattoo, but they should be ensured that the needle is new or the sterilized one. So that is how we can prevent this infection. Next slide. So abstinence, I just told, referring from the intravenous drug use, referring from the unprotected sex, oral, anal, or vaginal. Next slide. I will just run through. This is, we have monogamous relationship. So one partner. Next slide. Protected sex. This is the what the we need to intervene, and we have to teach how to use the condom. First thing, to use the condom and how to use the condom. There are a lot of calls I used to receive. I had the sex and the condom fat gaya. I had the sex, condom slip ho gaya. And there is now fear of getting infection. And because it was a commercial sex worker or maybe anybody else, so we don't know the status. So what to do? So there are a lot of calls, and especially in the anal sex, we should ask them to use basically latex condom, which is different. I mean, latex condoms are also, but for the anal sex, there is a thicker and the larger condom. So one should use that. So we have, I can take the whole class on the condom also, but this is the basic thing which every physician should know, every student should know, to use a condom and in the every sexual contact. Next slide. When using a condom, this is again a very interesting thing, basically because people used to ask. I don't remember the one series we were seeing, there was a thing, I mean, how to make him, so वो जो है उसके condom में check कर देते हैं. So condom में check करके कि the friends are giving to, now you go to your wife and we'll see. They don't want the child, but they are just doing. So this is the anecdotal thing. So only every time one should check when you are keeping this in the pocket, so it is not damaged, it is not expired, it is not torn, and it is not the pricked, it is not the defective condom. So one should remember all these things. Next slide. I think I have done. So test and treat is the new modality. Everything diagnose early for the physician, for the young students. Early diagnosis is very important. Everybody should think of, please keep this in part of your differential diagnosis of any fever of unknown origin, any long diarrhea. Dr. Rewari has already mentioned where we should think, any STD, herpes, TB. So you should check, and wherever you feel to test, basically simple test, one can test it. Better from even the CT, MRI, just do a simple blood test in your workup. So thank you very much. I am open for the questions.
Thank you, Dr. Ruby. And now we throw this question open to the questions. Anybody having any questions?
Dr. Ruby, since you mentioned about prevention, and
Yeah.
you mentioned all prevention measures, maybe you would like to mention something about pre-exposure prophylaxis also at this stage?
Yes, sir. Yes, sir. Basically, because it was the group of PrEP and PrEP, I thought I will just take. Yes, definitely. You are very rightly said. There is a pre-exposure prophylaxis also. Pre-exposure prophylaxis, especially for the discordant couple, for the MSM, gay population, commercial sex worker, and basically who wants to go for the sex and with the partner, unknown status, so they can, although the best is it is not a replacement, please, I am very much into this thing, it is not a replacement of the condom, because with the prophylaxis, this is an additional tool with the condom in the prevention basket. But not only but we have the prevention pre-exposure prophylaxis available, we have the post-exposure prophylaxis available. So people who are having the partner with HIV status, so they can use both the condom as well as, if they don't want to use the condom, so at least the pre-exposure prophylaxis. But it is not saving the pregnancy, it is not saving the STD, it is not preventing from the STD. Yes, Rewari sir, maybe you can just make a further comment.
So any questions?
Any questions? Or
I put in the national guidelines, NACO guidelines in the chat box, and the
Yeah.
link also you can download from there if you don't have.
Madam Namaskar, Dr. Saroj, Madam Namaskar. So maybe the madam, aapka koi comment? Dr. Saroj, I can see Dr. Saroj is there. I am humbled to see madam.
No, it was a very nice talk. I heard it on the other channel. And as always, as usual, you elaborated on everything. So I really have no question. I do not have so much knowledge about both the diseases, or not like you. So that was a very good talk. Very
Thank you.
well done, Ruby.
Thank you, madam. Thank you. I mean, it's a great motivation. Once you are attending the such sessions, so it is a really real motivation for, I think, all of us.
Yeah.
Not only me and all of us. Thank you.
Dr. Ruby, we also welcome Dr. Arora, who has
Yeah.
joined recently. He is past president of EDPA. Dr. Arora, you are welcome, sir. In case you would like to say something.
Sir, namaskar.
Hi, Dr. Ruby, it was a wonderful lecture. We have covered all the aspects, whether it is the treatment part or the investigation part, and how we are doing it. And it's wonderfully covered and equally supported and moderated by Dr. S.K. Gupta, and with the guidance of our worthy Dr. B.B. Rewadi. Thank you, Dr. B.B. Rewadi, sir.
It is always a pleasure, Vijay, to be in EDPA meeting. And I'm pretty sure this series will actually enlighten the members when we have more details about the treatment in subsequent
Yes, sir.
sessions.
Yes, sir.
Dr. Arjun, would you like to say something?
I think all the basics have been covered very well. Very important point that that has been discussed, and that I would like to emphasize is, as a pulmonologist, we encounter pulmonary tuberculosis all the time. So all of us as physicians, whenever we encounter a case with TB, whether pulmonary or extrapulmonary, we must ask for the HIV status of the patient. Very, very essential.
Just to supplement that, Dr. Arjun, the guideline are basically that all patients with TB should be offered a testing.
Yes,
of course, it is not mandatory. And because the prevalence, we know the prevalence is quite higher in these groups, all patients with STIs. And also we should offer actually HIV testing to all antenatal women also. That is more for prevention of mother to child transmission. And these are guidelines. Most of the gynecologists are doing this routinely, but these are the three categories. But if you have other kind of infections that we have seen during the presentation, particularly opportunistic infections, like meningitis, toxoplasmosis, they should all be actually, first possibility in your mind should come to be HIV. Any unusual manifestation of illness or a prolonged duration which is not responding to usual treatment, HIV should come to your mind.
Sir, are there any changes in the consent scenario? Like we were previously, there was a lot of advertisement that the consent must be taken before we subject a patient for the HIV treatment.
What should be taken?
Consent.
Consent.
Yes. For testing, consent is a must. For any HIV testing, consent is a must because this is the issue of human right. We can discuss that there is right of the doctors also, but this is the guideline.
The consent has to be an implied consent or it has to be a written consent?
Informed.
It has to be informed consent. It need not be written consent, but sometimes you may have issue how to prove that consent was taken.
So I have a question for Dr. Rewari.
Yeah, please.
So if a patient who we have diagnosed to be having this disease, and the patient came to us for whatever problem, and during the hospitalization the patient was found to be positive for the virus, in our discharge summaries, how do we give the diagnosis? Can we write HIV positive, or how does that work?
We should actually avoid labeling like HIV positive. We can say immune deficiency.
Yeah.
You can basically write immune deficiency, which people will not understand. But if you write HIV positive, this becomes an issue of labeling. There is a lot of stigma, and people can really sue you also in the court that you have basically discriminated and put them in the stigma issue.
And sir,
definitely you should write immune deficiency so that
immune deficiency or PLHA.
And sir, is the NACO doing anything to include these patients in the insurance, the TPA? None of the insurance companies cover patients who turn out to be HIV positive, which is very disheartening to see. On one hand, we talk about equal rights, but on the other hand, none of the TPAs do anything about this disease. So is there any government plan to ask the TPAs to take these patients on board?
When I was in NACO in 2014, we had actually a meeting with all the insurance companies, regulator and all those people. But issue was that they tend to hike their premium significantly, because at that time in 2012-13, ERT was still more expensive compared to now. But as of now, Star Insurance is one which includes Star Health Insurance, which includes PLHIV, but the premium becomes higher. Other companies have not agreed as of now for insurance.
Sir, important Arjun is mainly, and which I am facing every day in the hospital, the patient admitted for some other problem, maybe for the surgery, maybe for the tuberculosis, or maybe for the pneumonia. Once he has been diagnosed HIV, his approval got, he didn't get the approval for the TPA, and it is rejected, and patient has to pay from his pocket. This is very difficult for the patient, for the hospital, for us. And it is, I think I have raised in every meeting with ECHO and every meeting with the SI, because this is a pending issue, sir. I think this is a high time. We should take this issue. Every day it is a problem.
I know, Dr. Ruby, this has been taken up by you, Dr. Gilada. There are people who are part of NACO teams now, and this is an ongoing issue. Actually, it has not been resolved fully that these are not excluded from insurance.
I think most of the questions have been covered, and there's a time to thank all the chairmen and the speakers. I hand over back to Dr. Paras Gangwal to thank all the guests and close down the meeting by Dr. Swati.
Yeah, very good evening again to everybody. I think it was a wonderful session, a lot of learning, a lot of teaching. For people like me who know so little about HIV, I think it was a wonderful session. I'll be posting some queries and my framed answers for them in the prescription format as I told you, and I'll get it verified by the esteemed panelist whether those prescriptions are right or wrong. I'll try to do that in some days, and I think Swati would accompany me in doing that. The clinical scenarios based on whatsoever we learned today and our proposed answers to the situations, and we'll get them verified by our esteemed panelists whether we are perceiving it right or wrong.
That is a wonderful way, Dr. Gangwal.
Yeah.
Yeah.
So
and this PPT is also on the EDPA group, so anybody.
Yeah,
can...
I'll go through the whole session once again in depth so that there's nothing lose on my learning from that. Okay, and then I produce that to you and get it verified by you people.
And this is an announcement, Dr. Paras, that we will be meeting next Friday, this time again around 8:30 for the opportunistic infections in patients with HIV.
One request from my side as one of the keen learner and practicing physician, can we accommodate these sessions a little further, maybe 9:30? Though I may not get free by 9:30, it's not as President EDP, it is as one delegate who wants to participate, but is a practitioner also. Though we'll be providing everything on the YouTube, but being there live, listening it live makes a lot of impact. Can we push? I mean, I'll leave that to you, Pankaj, and all to decide. Can 9:30 be a better time than this?
I'm early to
Ruby
bed.
being a woman has a lot of issues.
And the only thing I'm a person who is early to bed and early to rise. The person.
All right, I'll leave that to the team, and whatsoever you do
9:30
finalize,
will be
that
too
will
late.
be okay.
9:30 will be too late.
Too late. Yeah, many people may not like.
Even there was some resistance by Ruby from 8 to 8:30, but we requested and she agreed.
All right, so day timings is all over to you with whatever maximum participation we can get. That's just a request as a delegate, right?
Okay,
So thank you very much. Thank you, Dr. Rewari sir, for the wonderful session and clearing all the concepts. Thank you, everybody from EDP side. I'll hand over the mic finally to Pankaj or Dr. S.K. Gupta to conclude.
I think the conclusion part is to be done by Dr. Swati, who is the secretary of the EDPA. And thank you all. Thank you, Dr. Rewari especially, and Dr. Ruby Mansal, and Dr. Pankaj, and Dr. Arjun Kharate.
Thank you, Dr. Ruby. Thank you, Dr. Rewari and Dr. S.K. Gupta for the wonderful pearls of wisdom as far as HIV is concerned. I think we learned a lot today, and I hope we'll be learning much more in the upcoming sessions. And I'm really happy to meet Dr. Rewari, sir. A few of your books and mementos are lying down in my room, in my cupboard, actually, in RML.
Thank you, everybody.
Okay. you, Vijay.
Now we close down the session. Thank you.
Thank you. Thank you.